The Australian Government and partners came together and formulated the National Safety and Quality Health Service Standards. This framework is broken into 8 categories, each providing insight into the significant role each standard has in ensuring safe care. In the Learning from Error video, there are many actions that deviate from the standards and are therefore unsafe. These include medication safety, partnering with consumers, and clinical governance. The standards clearly state the appropriate and safe storing and administration practices for medicines like vincristine. Furthermore, the standards outline the healthcare team's responsibility to provide safe and quality care for their patients, whilst ensuring their patient is involved. Due to these oversights, Jane the patient was put at risk. This could have been dramatically reduced by the healthcare team observing the national standard communicating for safety. In order to reduce the risk going forward, communication needs to be improved. This will be done by working towards ensuring 80% of clinical handovers directly involve the patient by January 2020 through the use of bedside handover. All members of the healthcare team, including nursing staff, the allied health team, and medical officers, will need to be involved in order to create change. This includes senior staff, as the interventions will need to be approved and endorsed by hospital management. To achieve this goal, all medical staff will need to work together to follow the interventions put in place while creating an environment where all individuals feel heard and validated.
The problem in the video, Learning from Error, that we are exploring through the Communicating for Safety standard is the lack of proper communication and handover between the nurse to doctor and doctor to patient before the patient's chemotherapy procedure. It is fundamental to involve the patients in clinical handover to avoid risks and improve patient safety. Communication between the health professional and patient is vital to provide safe diagnosis, proper documentation, and safe medication administration. According to the NSQHS standard, meaningful implementation of this standard requires attention to the processes for partnering with patients in their own care and for safely managing transitions between episodes of care. Hospitals should follow the policies and procedures outlined by the NSQHS, as well as organisation-run systems to support effective clinical communication. In order to provide quality communication between patients and healthcare staff, the policies and procedures that are put in place have to place patients as the key participants within clinical communication, as well as having the involvement of carers and families in the communication of strategies and processes needed to be performed on or by the patient. Issues that resulted in the communication problem, reaching the extent and damage it caused, stems from the lack of communication during the handover of the patient between each nurse and doctor. There are many healthcare professionals who were taking care of this patient on this particular day, and the level of stress and time restraints impacted the level of effective communication that should have been present between the healthcare professionals and the patient. The overtaking doctor, who was new to this particular hospital, was uneducated on the procedure that needed to be performed on the patient. He seemed to be in a rush, which led to the inadequate communication and rushed conversations between the other staff in the pharmacy and the nursing staff. There are many risks involved in clinical communication, such as noise, interruptions, inadequate time, absent participants, and inaccurate information. These were all present within the clinical scenario. They all led to the patient being put into a critical, life-threatening situation. According to the 6th standard, Action 1.10, the organisation-wide risk management system needs to be able to identify, assess, manage and document organisational risks associated with poor clinical communication errors, which could include communication errors that result in misdiagnosis, miscommunication of clinical information at clinical handover, and other communication errors, which were all touched upon in the Learning from Error scenario.
In order to achieve 80% of clinical handovers directly involving the patient by January 2020, interventions will need to be put in place. In order for communication within the healthcare sector to improve, it is necessary to evolve the way bedside handover is traditionally presented. The acronym ISVAR is a communication tool used by the healthcare team. This communication tool was developed to improve handover communication and ultimately patient safety. Although useful and used frequently, the current framework does not support the goal of including patients within the bedside handover process. In order for this substructure to support the planned improvement, the letter E will be added to the popular framework when used for bedside handover, thus creating ISVAR E. This new addition will represent engage and act as a reminder for the healthcare staff to actively communicate with the patient, whilst giving the patient an opportunity to voice any concerns and ask questions. In order for this change to be implemented effectively, all members of the healthcare team will need appropriate training. To aid in this training, staff huddles will be implemented at the commencement of shift. These dedicated huddles will be held quarterly, offering 3 different sessions throughout the month. This forward planning allows for rostering adjustments, ensuring all staff have the opportunity to attend. Although a small intervention, huddles will allow the healthcare team time to air any concerns, ask questions, and plan for the appropriate care of the patients whilst incorporating ISBA-E. And the importance of communication within the healthcare sector, it is vital that this intervention be spread across the entire institute. Due to this significant scale of change needed and the large number of staff that will require further training, it will be necessary to establish a designated team of professionals to carry out the intervention. This committee will be responsible for liaising with hospital administration regarding huddles, intranet memos, and auditing. These audits will be conducted during bedside handover at the beginning of every shift. These audits will provide a collection of data to be further analysed. These findings can show if the education shared in the huddles has been effective with the implementation of ISBA-E. Alternatively, the findings will exhibit any need for further interventions. Furthermore, this committee of professionals will require financial support to provide these services and backing approval from the hospital board. Patient communication improves alongside the implementation of huddles, ISBA-E and audits. We would also apply the use of bedside posters and patient satisfaction surveys. The simple implementation of bedside posters will serve as a visual reminder for staff when caring for patients and communicating openly with them. Placing these posters around the bedside will serve to encourage and remind the patient to feel included and empowered in the care they are receiving. In order for this intervention to be as effective as possible, we would ensure these posters are A4 size, brightly coloured, easy to read and understand, and contain all relevant information. Patient satisfaction surveys will also be implemented alongside the use of bedside posters. These surveys will allow patients to have the opportunity to provide feedback and potential criticisms following their care. These anonymous surveys will include questions such as, did you feel that you were included in your handover during your stay at this hospital? These surveys will be tailored to each ward's routines, allowing further analysis into the potential differences in patient satisfaction and involvement depending on the area of the hospital. Given the importance of communication within the healthcare sector, the need to ensure this intervention is spread across the entire institute is paramount, and as such, like Intervention 1, will require the support of the ISBA-E committee and senior hospital management. To measure the effectiveness of these interventions, the ISBA-E committee will organise the collection of these survey forms and analyse the collected data. This data will then be used to both highlight areas of improvement whilst pinpointing other areas that may require further assistance. Analysis of these discrepancies will allow the ISBA-E team to identify the risks and impact other circumstances have on the team's ability to communicate for safety.
We'll be measuring if the interventions were successful or not. We want to gather our data and statistics through the process of patient and staff surveys, specifically questions of patient involvement, if they had the opportunity to share their views regarding their procedures or their care. There will be a measurement period of 18 months with our goal date of January 2020 in there, with the opportunity to also extend the measurement if needed. With the learning from error video, Jane had no involvement in her patient handover. Therefore, we are setting the patient involvement at 0 to begin with, leaving lots of room for improvement. Our data will be displayed through the use of run charts and annotated run charts. These are graphs of data over time. They can determine if an improvement has been made or after a change has been implemented. They can also help the improvement team formulate assumptions or implement new interventions depending on how well or poorly a process is performing. Run charts allow for interpretation and patterns to be identified. Can be continued to measured after the implementation or the goal has been reached. We'd like to also make sure that you can see that there are standard deviations before and after the changes have been implemented. You want to be able to see the averages, be able to question why there is the change that it is, why there's an improvement. That's why we are using annotated run charts. We'd also just like to specify that these are examples only. These are not real statistics that have been used. These are just what we'd hope for or what as an example to see what is happening.
Through the report, 53% of the medical officers involved stated that the current shift-to-shift handover practices could be putting patients at risk of adverse events. 98% indicated that the handover process could be improved, but 100% stated that the quality of handover varies. Throughout the video, there is no handover that involves Jane. Ways to spread the change would be to have staff room memorandums, posters, emails and ward meetings, as well as hold random auditing at times of bedside handovers. The study into how the handovers are being performed is important to show you the level of patient involvement. Posters at patient bedside. The idea is small, but it implements a big change. Poster presentations achieve success in increasing knowledge, changing attitudes and behaviour. Having these not only where clinicians can see, but where patients can see, will evoke patient involvement by showing the patient that clinicians actually want them to speak up and be a part of the handover. During huddle is where the implementation would start at a 14 level. The information on how to involve the patient in handover would be mentioned here prior to the shift starting and would then be implemented within minutes of hearing about it. This would assist in sustaining the use of ISBARE as it goes from education to practical use straight away. A way of monitoring the implementation of this change is to collect data from patients themselves. Patient satisfaction surveys have gained increasing attention as meaningful and essential sources of information for identifying gaps and plan for quality improvement. The data collected from these surveys would allow ongoing study into the effectiveness of the change and allow further patient input.